All right, thank you, Dr. Higa, for the time. I appreciate you having me. Thanks, everyone, for making out time to join this meeting. Usually, we have this hands-on session, so it's more informative, and participants have the opportunity to try their hands out. But given the COVID situation, we are here on a live webinar, and we hope that you find this session very informative. Basically, we want to just review three key things, the principles and terminology, applications, and we would also try to see very high level in obstetrics means volume acquisition is that with 4D, time is added, and so that gives us the real time effect, or time is a quantity that is introduced. That gives us a real time effect. So in simple terms, you would see the baby sucking the finger, for instance, since this is the most common mode of 3D, 4D, most persons are acquainted with. You see the baby sucking, you see the baby moving, the hands or the legs. That real-time effect is caused by the time component in the 4D algorithm. To acquire 3D and 4D images, basically our normal 2D images are being acquired in very rapid succession, and in computer terms, we say they are stacked together. So if you can see my cursor, this is a typical 2D frame. It has length and breadth, but when we stack a lot of the 2D frames, we would have a sense of depth, and that gives us a volume effect. Okay, so acquisition of a lot of 2D frames put together will give us a volume set. This volume set becomes our primary 3D image. To acquire a 3D image, the operator can do this manually or automatically. So previously, in a similar fashion that you would do your normal stroke across the patient's abdomen, 3D was acquired in this manner. So the operator have to steadily move the probe across the anatomy of interest until the acquisition is, the anatomical area of interest is covered, and then the machine processes the image as a volume set. Today, this is done entirely by the machine. The operator will just have to place the probe, and the machine would, the probe assembly is designed to acquire the volume set automatically. So because there is an extra component, the mechanical component added to the probe, it implies that the probe will be a lot more bulkier and a lot more weightier than the conventional 2D probe. So on this image here, I have shown, we can see rather a 3D or a volume probe and a conventional ultrasound probe. You would observe that the volume probe has got more bulk compared to the conventional ultrasound probe. And this has a ergonometric consequence. It means that, one, the operator might feel a lot more stress on the shoulder, on the arm that he or she uses to scan, just because of the weight of the probe. I know a lot of companies are trying to work on the weight to produce more lightweight volume probes. Secondly, when we stack this image, one of the compromises we have to make in acquisition of a volume set is that the image quality compared to a standard 2D image, the primary image will be degraded. So degradation of image quality is a consequence of volume acquisition. And we encourage, based on this, we encourage practitioners not to necessarily do 3D acquisition where fine details, centimetric and millimetric details, they need to identify microcalcifications in a lesion. Whenever this is our focus, we suggest that we go ahead and complete the scan using the 2D probe, simply because it would still preserve the image quality. Once acquisition is complete and the volume set is being generated, how we view the 3D image is up to the operator to decide. So this introduces the subject of the modes of image visualization, which I'll be talking about in a minute. When a volume set is being acquired, right? So let's go back to the elementary physics, where we have the elementary vector physics, where we have the x axis, the y axis, and the z axis, or the all axes meet at a certain point, right? So that's where we should derive our concept of volume acquisition and our understanding of 3D, 4D imaging. So all of these images start together, interact at one point, the isocenter of reconstruction, right? That point is a dynamic point. The operator has the privilege of moving that point based on the machine setting. So Dr. Sheila is going to be doing the live demonstration, and he might be able to reflect on this. But it is important to know that we should be able to align our anatomy of interest to the isocenter of reconstruction. And that is a skill when practicing 3D, 4D. It is also important to note that the surface area of the anatomy of interest that the operator intends to cover can be manipulated. It's depending on the operator's preferences. So I'll introduce the concept of acquisition angle. Okay, so whenever we want to perform 3D, 4D, let's bear in mind this simple fact from this slide. One, let's adjust our acquisition angle such that it covers the anatomy of interest. Two, let's align our anatomy of interest to the isocenter of reconstruction. And that will really help us during our 3D, 4D acquisition. In addition to these 2 points, to improve our success of volume acquisition, the 2D image. The 2D image should be acquired in profile or in the best anatomical plane preferred, right? A profile image, for instance, is very key to the successful reconstruction of the baby face rendered mode that most of us have to have a good acoustic window before the anatomy of interest. And then thirdly, we did mention in the previous slides that the isocenter of the anatomy of interest should be aligned to the isocenter of reconstruction. That is true. It depends on the mode. However, there is the fourth or the fifth component or element, which is the reference reconstruction plane. This appears to be the line of sight, right? How is the operator going to see this anatomy? So if you pick your palm, for instance, and you are looking on fast to your palm, the immediate surface of your palm is what the machine renders in a surface rendered mode, right? So the reference reconstruction plane serves as the observer's eye. So if you can see my cursor, there is a green line over here on this image, over here on this image, right, and over here on this image. That would serve in simple terms as your eyes. Those are your eyes. Those are the observer's eyes. And what is the observer seeing? The observer is looking down on first to this fetal anatomy here. So the immediate anatomy that you see becomes what the machine renders, right? So it means that if our reference reconstruction plane is intersecting any other structure apart from the anatomy of interest, we will be unable to see our anatomy of interest. And I give an example here. In this image, we found intersecting the position of this fetal path difficult or maybe impossible. In this example, we can see the reference reconstruction plane is intersecting the fetal anatomy here. It also would make the visualization of the desired anatomy to be impaired and will introduce an artifact. So when we look at this image, you might find some dark areas here over the nose, for instance, that might be indicative of an artifact because our reference reconstruction plane was intersecting with a certain part of the fetus, maybe the nose. In summary, to be successful or to make a successful acquisition of our 3D, 4D image, let's recall that one, we need to manage our acquisition angle. Two, we need to align our anatomy of interest to the isocenter of reconstruction. Three, we need to maintain a good 2D image. This is very important. The 2D image is the primary image for which the 3D volume set is being acquired and rendered. The sense and clinical utility. Four, we should try to maintain a window before the anatomy of interest. And in that window, we place our reference reconstruction plane. The reference reconstruction plane should not intersect with any other anatomy before our anatomy of interest.
So now I'm going to mute myself. Start sharing your screen before I mute.
Just a minute here, I will start. Okay. Yeah. Can you see my screen?
Yes. So from there, yes, you can continue from here now.
Okay. Great. So we're going to talk about some modes of 3 and 4D ultrasound. Let's always remember that the mode of 3D, 4D is simply how the operator wants to visualize his or her image. The intent, the clinical intent for this ultrasound or for the ultrasound is basically to answer a clinical question. And so the operator will display the image in multiple ways to answer the clinical question. We all know that 3D sometimes, 3D, 4D ultrasound sometimes is being used for the cosmetic and social benefit. But let's always bear in mind that there should be a clear clinical indication for before this is done, before the patient have a 3D, 4D examination. In a multi-planar mode, this means that primary image and the A-axis, we can derive a B-axis image and a C-axis image. Now, note that the machine doesn't know if it is axial, sagittal, or coronal. But if the primary image, which is indicated by the A-axis here on this particular image frame, If the primary image is an axial image, the B axis and the C axis would either be a coronal or a sagittal image. As we can see here, we have an axial cut, we have a coronal cut, and we have a sagittal cut. Note that the image quality of the sagittal cut in the C axis is much more degraded compared to the primary image in the A axis. So like I mentioned earlier on, one of the consequences of 3D or volume acquisition is a loss of image quality. Tomographic imaging mode is a mode of display where the primary image is being rendered into multiple tomographic planes by the operator. So the operator recognizes a region of interest and introduces multiple tomograph planes on that image of interest. The machine will render each tomographic plane indicated here by this straight line. So we have multiple straight lines there, right? Each one is a tomographic cut, and each image here and here, all the way down here, is a representation of each tomographic plane. Now that the ROI starts from the top up here all the way down, and so what the operator intends to do, or is asking the machine, I have identified this region of interest. Can you give me multiple tomo slices across this region of interest and display for me? So once the operator has set this on the machine, the reconstruction algorithm renders these images automatically. And you can see the anatomical variation on each image plane as we progress superior inferiorly. In the surface rendering mode, which most of us are acquainted with, it displays the surface anatomy of the structure that the operator is interested in. So in this case, for instance, the baby face, as it's normally called, right? We can see the baby face nicely demonstrated here, derived from the volumetric set. So most machines will display all 4 images at once in the A, B, C, and the surface rendering mode, as we can also find on this image. The surface rendering mode is limited to visualization of surface anatomies of interest. Other modes, other surface rendering modes include the transparent mode and the inversion mode, as we can see on these slides, and also the virtual light mode. The G team calls it the HD light mode, and it has been shown that this has a lot of social and cosmetic benefits. We have the Omni view and the virtual contrast imaging mode. We recall that in the previous slide I had mentioned that for us to have a successful 3D 4D acquisition, that we need to satisfy certain criteria, which includes a nice anatomy in profile, having the acoustic window, and placing the reference reconstruction plane in the acoustic window so that it renders the surface anatomy on fast to that reference reconstruction plane. Now, this satisfies the conditions for the surface rendering mode, which we've talked about in the previous slide. But with technological advancement, the virtual contrast imaging and the OmniView mode rules out the dependence on these criteria. So it, one, gives the operator the flexibility to work without having to use, to depend on an acoustic window, like the fluid before the structure of interest that I mentioned. And two, there is no more dependence on the profile anatomy in 2D. So in this image, we have an axial skull, fetal skull. And we have our reference reconstruction plane indicated by this observer in turquoise, and another observer in yellow, and another observer in purple. The operator have the choice to introduce as many observation points as he or she would desire. And the equipment would render for us the corresponding images, as we can see here, here, depending on what the observer would want. So in this case, we have this scenario. We also have another scenario where we have multiple observation points, and then we have multiple coronal images. The value of the OmniView and virtual contrast imaging can be best demonstrated on this scenario, where on surface rendered mode we can have this appears to be a cleft palate, a cleft lip, sorry. But if we introduce an observer and the operator inserts and manipulate and draw out the reference reconstruction plane through the baby's mouth or hair to study the fetal palate. So while on the surface rendered mode, we can see the cleft lip. On the virtual contrast mode, we have the enhanced capability to even study the palate. And now this is also applicable in gynecology ultrasound, where on this image we have the uterus, but we've introduced the reference reconstruction plane here. It's curved, so it suggests that it's not always a straight line, and it can render for us the image of the endometrium so the observer can appreciate what's going on in production of saline or any of those invasive maneuvers. Finally, in this presentation, I'll refer to the static temporal image correlation mode, the STIC mode. Now, fetal echocardiography is a growing discipline. It's been perceived as highly specialized. Operators are considered well skilled, and sometimes they say that it's difficult to acquire all the standard images that is required for complete assessment of the fetal heart. What STIC does is, by basic acquisition, volume acquisition of the baby's heart, and by proper placement of the imaging isocenter, all the views that are required for a complete fetal echocardiography include the fetus view, the 4-chamber view, the 3-vessel trachea view, even additional views like the aortic arch view and ductal arch views are all displayed automatically. Now we know that this is going to save a lot of time, and this has got a lot of benefit for the interdisciplinary team management of the baby. So when this patient lies on the table, and with time all views are displayed, and then the images are sent up for evaluation. So that's really good. And then to add that once automation comes together with 4D, most authors are beginning to refer fifth dimension ultrasound, and that simply just means that in addition to the 4D, we add certain levels of automation. I'll be talking about some applications of 3D, 4D ultrasound in obstetrics. How is it applied? Apart from the baby rendering, what other applications do we have for 3D, 4D? The uterus, 3D, 4D has been very visualization of foreign bodies, including the IUDs. So we just want, is there an extravasation or is there a dislodgement of an IUD? Most authors have reported the benefit of 3D, 4D imaging to delineate where these foreign bodies are located. Also, lesions could be characterized, and the good thing is that this can also be deployed alongside sonohysterography. So we better characterize lesions, as we can see on this slide here on this image. The uterine structure can be studied more in detail, more appropriate is involved, right? So we have all the acquisition, and pay attention to the reference reconstruction line, which is bent through to cut through the endometrium, and this is the resultant reconstructed image. In gynecology, most practitioners are beginning to find 3D, 4D very helpful, especially when it is being overlaid with the power Doppler mode to define the tumor volume or to even characterize the tumor. In the ovaries, 3D, 4D helps us to further characterize the lesion that is being seen on 2D, as we can see on the image A here. And also we know that it has improved our ability to conduct follicular studies and folliculometry much more easily on a mode of 3D, 4D called the Sono AVC, right? So we can see, and this, we can see the ovarian structure, we can weight the ovarian, the follicular volumes, the follicular reserves, and stuff like that. So this means that 3D, 4D has a big role in infertility management. Also, when overlaid with power Doppler, it is a very good tool to understand the vascularization of the tumor in the pelvis and the blood flow characteristics as well. Talking about the blood flow characteristics, this is very helpful when we're studying lesions in suspected endometrial. 4D ultrasound, when overlaid with power Doppler, can show us the vascularization characteristics of this lesion, and that this can be indicative of the lesion's activity, if it is active or non-active. And also one study by Osbey also suggested that this can 3D, 4D combined with power Doppler can help us to understand treatment outcomes in pelvic inflammatory diseases. Again, the clinical utility of 3D, 4D should be dependent on the clinical scenario and the intended clinical question to be answered. In this case, we can see multi-planar modes overlaid with power Doppler to understand the vascular characteristics of the lesion in question. 3D, 4D also finds application when we're studying the pelvic floor. So many authors are beginning to demonstrate this, and we're beginning to see much more studies coming up. 3D, 4D has a lot of application to study the pelvic, especially looking at the changes that occur in the level with the levator and ani muscle, and also the puborectalis. And even if there's a clinical suspicion for prolapse, organ prolapse, we're beginning to see that 3D is making a huge impact in clinicians understand the pelvic floor anatomy. Still on the pelvic floor anatomy, I want to draw our attention to the tomographic ultrasound mode and its application here. So this is the primary image, and we have multiple tomo cards set over, tomo references set over the region of interest, and we have the resultant images being displayed here. So I'm not going to talk about the technicalities and how this exams is being conducted, but it's important for us to appreciate that this, to appreciate the applications of 3D, 4D in pelvic floor imaging and clinical conditions associated with this. In this image, this author tries to make a comparison between ultrasound acquisition and MRI acquisition. And they found that there was moderate agreement between 3D ultrasound and MRI in left levator ani defects in these nulliparous patients. Finally, I'm going to refer to the applications of 3D, 4D in laparoscopic surgery. Now, this is a growing field. We just have a couple of scientific evidence coming up, but basically the 3D during the surgery, just to further characterize the lesions real time. So you might want, if the desire is to understand, is there an all clear indication before we close up? Did we do a thorough job? Do you just want, in addition, to put the probe and allow and be guided to see, is everything clear? Are we green? Can we go ahead and say we've done a good job? Then these authors are reporting that 3D, 4D is beginning to find an application to answer such clinical questions during laparoscopy surgery. I hope this has been helpful. Dr. Shile is going to take over from me and do some real-time demonstration. Thank you.
Thank you very much, Ayo, for a very lucid presentation. I'm sure that we have a firm foundation to go ahead and continue the presentation. So thank you very much, and we'll be proceeding with the second part of the lecture, which has to do with demonstrations. Start by showing few 3D images, and then we'll go ahead to talk about the basic planes of acquisition, after which we'll talk about or do a live demonstration. Thank you very much. 3D ultrasound could make very clear to us. You notice that the baby didn't have any nose here, and you see the general fascia of this child. Now, I want us to look at a practical example of how to check out the images with 3D. Before I go ahead, I would want to share the screen. I'll stop sharing this screen, and I'm going to start sharing the screen of the computer, or of the scanning machine, sorry. Okay, sorry, just a minute now. Okay. So this is the scan machine screen. Can you see the screen, sir?
Let me see. I can see. Yes, I can. That's good.
Okay, so you can see the screen of the ultrasound machine now. All
yes.
Right. Okay. So I just wanted to show an image of this is what we normally would see with a 2D scan, and it's an unfortunate situation where we this client actually presented and had an IUFD. But one of the things I want us to note, in this image, is that I want to go to one of the 3D images, and at this point, I want us to know, we're going to talk about the image acquisition, but for now, I want us to talk about the planes. Ayo had told us about the A, the B, and the C planes, or the X, the Y, and the Z planes. And I would want to reiterate that a good 3D image would normally start with a good 2D image. And I'll explain something from this image. Now, I'm holding a phone in my hand. And if you look at this phone is quite horizontal. And if you remember how we plotted the graph, you have the x-axis and the y-axis. So when we manipulate our image, if we do any manipulation along the x-axis, what it's going to mean is that we're rotating this image along this x-axis this way. This is what we're going to be doing. So, and for example, if you look at this image on the screen, just imagine that this is the image and I'm rotating it like this. So now on the screen, what I'm doing is doing the same thing. Can you see? I'm trying to rotate the same way I'm rotating the phone along the x-axis. So this is one of the things we can do. Now, if I want to rotate an image along this axis, this is the y-axis, and as I begin to rotate round like this, I'm rotating along the y-axis, just like we'd see in a graph. And then if you look at this image, you could see that we're rotating along the y-axis. This is important because apart from acquiring the image, knowing what exactly to do with the image is important. And then lastly, if we begin to hold this phone like this, and instead of rotating like this or rotating like this, I begin to turn the phone like this, like a cartwheel, it means that I'm turning it along the z-axis, just the way I'm doing for this image over here. Now, so these are the basic axes along which we rotate images. Now, I said that a basic or the key to a good 3D image is a good 2D image. When I took this image, the gain, I specifically made sure for this demonstration that I increased the gain specifically. And even on the 3D image, as I increase the gain, can you see how the image becomes more distorted? And as I reduce the gain, you can see that we begin to have some fine details. So basically, just little tips. Good 2D image is the key to a good 3D image. That's number one. And then we'll know how to use our gain, our TGC. And then certain machines come with auto optimization. Now, I want to show us certain examples. And then I'll just show us, then we're going to do a scan. Now, this is example one. Sorry. I'm turning off. Sorry. I'm sorry. I hope I'm not showing any patient information. Example, specifically the face, and this because most people who want to see 3D scans are asking, okay, can I see the face? Is it a boy? Is it a girl? Now, with this acquisition, AO has told us that we have to ensure that we have maximal amount of fluid before we take our images. And again, to manipulate the image, we could go any direction. You see, I'm going in the Y direction. So you find out that you hardly make mistakes in telling the sex of the baby. This is the X, you go like this, or this is the Z. And then AO talked about other things that we could do, like using the HD Live, playing around with the light. You know, you play around with the direction of the light, depending on the feature you want to highlight, and many other things. So at this point, I think it's better to go ahead and demonstrate on a live patient. I have a very wonderful patient here, or a client rather, who has agreed for me to demonstrate with her. So I'm going to turn off my video for just 10 seconds so that she gets on the couch, and then I continue and you'll be able to hear my voice. So you're welcome, Mom. Please come and lie down here. You're welcome. Let me have one of the towels here. Are you comfortable? Please go up. And then have this pillow. Okay. So just make sure you're very, very comfortable. Thank you. Okay. So like for every, how many weeks now? 33? It's 2 weeks. Okay. So I have my video back on now. I have a client here who is allowing me to scan. She's 32 weeks pregnant, and then she's actually carrying twins. So we're going to try to see if we can get any body part. The main thing is just to see that whether we can show her any part of the body. So again, I apply a copious amount of gel. And like AO had told us, we're using a volume probe. This is not the regular probe. This is a volume probe, and it's heavier. So I would want to go ahead. We assume we've entered her details, and we want to go ahead with the scan. So at this point, I'm trying to do a scan. So here I am. I'm trying to get the face of the baby, and first of all, I want to see if I can get a 4D image. AO told us as much as possible, to try to put the image, to put a lot of fluid before our image. And I'm going to try to just increase the volume of acquisition and then go ahead to try to get. So again, if I check the image here, you would see that I'm reducing the gain. We can see part of the face, but it's not as clear as I want it to be, because there's possibly some interference. I'm going to go out. You can see why we had that was, you can see loops of cord here. So possibly these loops of cord were coming before the face of the baby. So I'm going to try one more time to see if we can see the mouth of this baby moving. And okay, I'm actually scanning, sorry, just 1 minute. I was scanning in the wrong mode. Very good. Because if you see, I was scanning in gynae mode, and meanwhile I also select the obstetric mode. So now that I'm in obs mode, most likely I would be able to get a clearer image. So again, this shows us that when you're doing a scan, you realize that the right setting of the machine is very important. So now look at this. What are we able to get? Can you see that we can see part of the baby's face? And somebody had asked, what do you do when you see some of these artifacts? You can actually take them out. So again, I'm going to go out and then let's ask ourselves, how can we make our image better? We've been advised to, as much as possible, we should have our image in the profile view like this. And he told us about the reference dot. And now I want to try to see if I can get another good image, 4D image. So you see that depending on where my acquisition is, you notice that I can see the umbilical cord here, and then part of the baby's hand. Can you see the tongue, little tongue out? So now this is on 4D. So what if I go out? I missed that. I think we need to see that yawn again. We missed the baby yawning. So again, I'm playing around with the gain, with the volumes. Sometimes it could be a little technical depending on how you can see we have a lot of movement from this baby. Now, I want to come and check here. I'm trying to, so since we're doing this scan for this client, I want to at least reassure her. You can see this is good here. So I want to change it to a 3D mode now. We try to show or demonstrate on 4D. Now I want to demonstrate on 3D. So again, we try to get, we see the baby opening the mouth again. So I try as much as possible to manipulate my probe to see that I have as good, and I increase my angle of acquisition. Sometimes you just quickly need to this is a little close to the nose, but then again now, you see, when I begin to play around with the gain, so this is not the best image. I'll save this because again, there's ability to do a lot of post-processing. I'm going to deliberately take some artifacts in so that we'll be able to bring them out as we scan. So again, I'm looking over here. I have the profile view. Notice that I still have part of the umbilical cord, so I try to narrow on my region of interest. So let's see what we can get here. This is the period of acquisition. Again, you can see that as I reduce again, we're able to tell, okay, this is the nose of the mother and all that. Now, this is probably not the best image we can get, but just to answer someone's question earlier, or this is the first baby, maybe let me see if I can see the face of the second baby. Are you okay? Are you comfortable? Okay, very good. So let's see what we can get over here. Another key to get good LICOR is to reduce the pressure of the probe. Baby is moving a lot. So Dr. Higa, I hope we can see the screen properly, sir.
Yes, the screen is very clear. Thanks.
Okay. So babies are moving so much, so I'm trying my best to see what I can do over here. So one of the things to do is, honestly, before starting a 3D scan, it's good to counsel the mother that sometimes, just like a photo session, you know, you need to have the perfect poses. Sometimes the babies are moving a lot. Sometimes you have things in front of the face. So I'm trying to see, okay, how much fluid I can get here. So we have the baby coming a little towards, I'm trying not to go against what Aya said. Let me not go too much into the uterus. Now, I'm going to do something deliberately on this image. You see that we see part of the nose is here, but we can't see a lot of things. So depending on what we said, for example, I begin to sometimes rotate to see, okay, at what point can I get some parts to cut out? You know, this is, okay. Sorry, you can notice the umbilical cord in front of the face. So that makes it a little, so if I acquire this image again, you may notice that, again, you have part of the cord in front of the face. Now, I'm going to do something just for 1 minute. Since she's carrying multiple gestation and she's lying down by the side, I'm going to have her turn a little to rest. But while she does that, I'm going to switch to see if I can show us how to edit an image that I took on a patient with polyhydramnios, where there was significant LICOR. But let me try to see if I can get one more image here. So the key again is, as much as possible, we try to be, for the face, get a profile, have a region of interest. You optimize the image for the 2D first, and then you select the right quality for the scan, and then try to see the image which you will get. So again, as I reduce again, you can see, I can see part of the nose of this mother. Now, let's assume someone asks a question that I don't like these things that I hear. What can I do? This machine, for example, you are able to, like I rotate, I go along different axes. So you see, as I rotate along the x-axis, I can see that whatever is here is actually not part of the face, is like an artifact. So I can quickly come, this very machine has something called magic cut. And for example, if I come over here and apply this tool, I may be able to get this. And now I can rotate back the face, and you notice that, well, I lost a little part of the forehead, but then the nose, now I can undo what I did. So, sorry, no. So, so the main thing now for the image acquisition, just summarizing, is that you get a good plane like this, optimize the image, then you obtain, sorry, I'm a little too close because advanced pregnancy, multiple gestation, we don't have too much LICOR, and I'm able to work with the image. For now, I would want to show us something. Hello, ma. I want you to just tilt a little to the side so that you're resting. Now, this is an image that was acquired some days back. And with this image, you can see that I tried as much as possible to get some features of the face. Sometimes it's a little difficult. So if I want to see, okay, how much of this face can I get? You see that depending on what I want to highlight, I'm rotating this along the y-axis to see, okay, what can I get out of this face? If I'm not comfortable, I come around the X and I say, okay, I want to remove whatever part I'm not interested in. So let's assume we just want to get a side view of this face and we're not interested in the hand. Again, we can use our cut tools, for example, and just the way a photographer may do. I just come and I steadily just try to go by the side. Well done now. Are you comfortable? Okay, thank you. And then I just try to see how much of the face I'm just trying to come out. So when I do this, you can see that I have a little view of the face. I have a side view of the face. Now, Ayo had told us that depending on what we want, again, I could play around with different render modes. I could play around with some lights, depending on what I want to highlight, you know. You could change the direction of the light and all that. The main thing actually is beyond, we could learn what to do with the image, how to crop, how to rotate the images. But in summary, I want us to take home today, after what Ayo has told us, is that number one is that we should remember that first things first, the key, thank you, the key to a good 3D image is a good 2D image. You notice that I've struggled to have a good 3D image because I've had some artifacts. I've seen the cord and some other things in front of the fetal face. And it will look like this is very easy to, you know, to achieve. But with more practice, we'll be able to get. So again, summarizing what he said, to get a true good 2D image. If we want to get the face, for example, we get the image, like the face, we get the profile. You open the region of interest, and then depending the volume of acquisition you want to get, you can adjust from the machine. And then you can just quickly take the volume. And after taking the volume, we can decide, okay, so this is better now. So you notice if I reduce again a little, I can decide to rotate, you know, this image. You can say, okay, let's take away. You see again, we have the tongue out. We have this. This baby doesn't have macro gloss here. We've seen this baby a lot of times. Maybe the baby is just having fun bringing the tongue out. So as I rotate, I can take out any artifact I'm not interested in. This is rotation along the y-axis. Again, I try to see, okay, what can I get out?
All right, let's round up, please.
Yes. So basically, this is just supposed to be a brief demonstration. I hope that someone is encouraged and not discouraged. Sometimes it can be a little technical, but at least we can see the nose. And the woman is here with me. I can see that the nose of the baby looks like that of the mother. So, Madam, are you happy seeing your baby? All right. So, sorry, this is what we can get for now. I believe that maybe when we have more time, we'll be able to spend more time scanning. Dr. Higa, over to you. I don't know if we've done what we need to do concerning the demonstration yet. I still have
you have done, don't worry, you have done more than what one would have even asked for within such a very short time. And I thank you for reminding us that, I mean, it's not all hopes lost. It's, I mean, we can always get there. I'm sure if you tell people that it's just like 2014 or thereabout that you entered into some things like this on a very low scale, but you kept going at it, and today you can do quite a great deal. So it shows that it is possible if we put our hearts to it. But a lot of things may have to also go as well, but we are very grateful to you. just a few things just to let people again know that it is possible. You need to have steady hands. That's very important. You need to have good skills in the 2D, the routine ultrasound. You need to be able to identify things very easily so that once you see it, you'll be able to quickly adjust. You also need a lot of patience and a lot of time is dedicated to it. So you can see that the babies don't pose for the camera. So you've got to look for them, you've got to trace them. And then it's important to note too that there are different machines. So just note that his machine has a lot of software inside. So some people may have the same type of machine and you say, why is it that mine cannot do that? The OmniView, you need to get the software for that. And then there are some in which you can invert the acquisition line. So if you don't have that software, you can only look at it from one direction. There are others in which even if the baby is facing down, you can take it downwards and look at the baby from there. So don't get discouraged if your machine doesn't do it. It's just the software and some of these things cut into that, then you may not need to spend so much money on it. So it's quite important. Somebody has asked at what gestational age can you start all this? You essentially can start it at early gestations, but because again, you've got to make sure that you take the interest of the baby at heart as well. So based on that, people want to say, well, why not wait till after 13 weeks before you start playing around with all these things? However, for those who do NT scans, sometimes you may have no choice but to get a good 3D image, and based on that, you are able to adjust effectively. So it's also quite there, and it's important.